Welcome. In my topic, we are investigating the correlation between oral health and comorbidities. My name is Caroline. I'm a PhD student and dentist with the Department of Restorative Dentistry and Endodontics. My supervisors are Zsolt Lohnai, Beta Keremi, and Dani Kozabo. My SMS is Petrona Martinkova, and our statisticians are Sylvia Kishtala and Gergely Akoc. My mission is to reduce the number of comorbidities which are associated with oral lesions. My vision is to educate the population on the importance of oral health and the impact that it has on our general health. So I have two goals. My first goal is investigating the prevalence of oral bacteria in cardiovascular samples. My second goal is investigating the effect of endodontic treatment on inflammatory biomarkers. And we use the methodology of a systematic review and meta-analysis. Cardiovascular disease is responsible for the loss of 18 million lives each year. Periodontitis, which affects up to 50% of the population, is associated with an increased risk of CVD. The more severe the periodontitis, the higher the risk of developing CVD. Our aim is to determine the prevalence of oral bacteria in cardiovascular samples of adults with cardiovascular disease. And our clinical question: what is the prevalence of oral bacteria in cardiovascular samples of adults with CVD? Our population are adults with cardiovascular disease, and we would like to detect oral bacteria in the cardiovascular sample by PCR or culturing methods. Our hypothesis is that oral bacteria colonize in cardiovascular lesions of adults with CVD. This is the search key we used in 3 databases, Medline, Embase, and Central. And we initially started with 16,260 articles, and only 113 were eligible for full-text selection. So in these preliminary results, we're showing the prevalence of Porphyromonas gingivalis in cardiovascular samples of patients who are orally healthy, patients who are edentulous, and patients with periodontitis. In the orally healthy group, the prevalence of P. gingivalis was 11% in the cardiovascular samples. In the patients with periodontitis, the prevalence was 23%, so more than double. And unfortunately, there were not enough articles for statistical analysis in the edentulous group. And then we made subgroups depending on the location of the cardiovascular sample. So we have the carotid artery, which shows 14% prevalence, the coronary artery, which shows 38% prevalence, the aorta, which shows 18% prevalence, and we also have heart samples and healthy vessel samples, but not enough for statistical analysis. And in conclusion, the coronary artery showed the highest prevalence at 38%. And here I'm showing the prevalence of AA in cardiovascular samples of patients who are orally healthy, patients with periodontitis, and patients who are edentulous. So there were not enough articles for statistical analysis of the orally healthy group and the edentulous group, but the group with periodontitis showed a prevalence of 10% of AA in the cardiovascular samples. In the subgroups for AA, the carotid artery showed 6% prevalence, the coronary 24%, aorta 3%, and there were not enough articles for statistical analysis of the femoral, inferior extremity, and healthy artery group. Again, the highest prevalence was the coronary artery at 24%. And our strengths are that subgroup analysis was made for several conditions. Rigorous methodology had been described and followed, and there were a high number of articles which we included. Our limitations are that CVD diagnosis was sometimes unclear. individual patient data was not always given, and there was a lot of pooling of the results. Periodontal stages were not well defined. And in conclusion, even a small amount of oral pathogenic bacteria in cardiovascular samples can have a huge clinical significance. Our data show that the coronary arteries are more susceptible to P. gingivalis and AA compared to other investigated arteries. Eliminating oral lesions and oral pathogenic bacteria may prevent or slow the progression of CVD. Our implication for practice is to improve interprofessional collaboration, encourage regular dental checkups, and our implication for research is to evaluate the effect of periodontal treatment in ORCTs for MACE events, and also to investigate the prevalence of oral bacteria in periodontally healthy and edentulous patients. This is our progress. And in my second topic, investigating the effect of endodontic treatment on inflammatory biomarkers. An endodontic infection affects up to 87% of the population worldwide. Endodontic infections may perpetuate systemic inflammation, increasing inflammatory biomarkers. An elevated high-sensitivity C-reactive protein can predict the likelihood of developing CVD. An untreated endodontic infection may potentiate the progression of CVD. Our aim is to determine the level of inflammatory markers in serum before and after endodontic treatment. Our clinical question: how does endodontic treatment affect the levels of inflammatory biomarkers in adults? Our population are adults with endodontic disease. We take a blood sample before and after endodontic treatment, and we compare the inflammatory biomarkers in blood. Our hypothesis is that root canal treatment can effectively reduce the levels of inflammatory biomarkers. Our clinical implication is to increase awareness of the role of the dentist in the prevention of comorbidities. And this is the search key we used in the same 3 databases, and our key articles all showed a significant reduction in the inflammatory biomarkers after endodontic treatment. This is our progress. We plan to submit the first topic by August 2024 and the second by November 2024. Thank you for your attention, and I'd like to finish with a quote from Thomas Berger: "The art and science of asking questions is the source of all knowledge." Thank you.
My question is regarding your second project. How long of a follow-up time do you plan to analyze in your second project?
Okay, so we plan to take a blood sample immediately after endodontic treatment, and then 3 months and 6 months post-treatment.
I had 2 questions for the first project. The first one is regarding the results in the first blood. We saw that in the periodontist, we had a fluctuation of results from 0% to 100%. Can that be impacted from the degree of periodontitis, or what is the cause? And the second one is, we saw a slight presence of oral bacteria and cardiovascular samples in orally healthy patients. So did authors give any clue why do we have oral bacteria in orally healthy patients? Thanks.
Thank you. So for the first question, there was no difference in the severity of periodontitis. They were all moderate to severe. And for the second question, oral bacteria, I mean, everyone has this in their natural microbiome, so we can expect it even in healthy individuals.
I would like to ask regarding your second project. You with your team were choosing the interleukin-6, as I remember, TNF-alpha and CRP as biomarkers. Can I ask you, I'm curious, why only these? They have some higher association with oral cavity infection or something?
So we chose high sensitivity C-reactive protein because it's more accurate as a predictor for cardiovascular disease. And with the other inflammatory markers, they were the most common amongst all of the previous articles. That's why.
Thank you.